This meeting is being recorded.
Good afternoon, everyone. My name is Sharon Rounds. It's my distinct pleasure to welcome you all to the Advance-CTR Translational Research Seminar Series. This year, we're doing a series of talks in which distinguished clinical and translational science investigators give us a overview of their work. And today we're just absolutely so pleased to welcome Dr. Rena Wing, who will be discussing behavioral weight control, moving from efficacy to effectiveness studies. Dr. Wing came to Brown from the University of Pittsburgh a few years ago, and she has established an extraordinarily productive research center on weight control and diabetes. She's been a strong mentor for many, many faculty over the years. She's been PI on a NIH-sponsored T32 for 16 years, recently renewed, and clearly mentoring has been an important aspect of her career. Dr. Wing has been extremely prolific with regard to research productivity, having authored more than 500 papers. She has played important leadership roles on NIH study sections and panels over the years, and is regarded clearly as an international leader in the battle against obesity and its complications, which are such an important health problem. So Rena, thank you again for enlightening us today, and we're looking forward to hearing more, learning more about your work.
Well, Sharon, thank you for that very nice introduction. Sharon didn't want to say that I've been here 25 years already. So she just was very nice and said, I've been here for a while, but it's been a long time I've been here. So I'm speaking today on behavioral weight control, moving from efficacy to effectiveness studies. And my goals in my presentation are going to be to present, first of all, 2 large efficacy studies of weight loss that I was actively involved in. One's called the Diabetes Prevention Program, or DPP, and the other one is Look Ahead. After describing those 2, I'll discuss the effects of translation of these interventions to community settings. So I want to begin by discussing the NIH stage model for behavioral intervention development. What this model suggests is that we have to begin with the creation and preliminary testing of new behavioral strategies, new behavioral interventions. This includes feasibility and pilot testing too. Stage 2 is what I call the efficacy studies. It's experimental testing of promising behavioral interventions in research settings with research-based providers. Stage 3, you move to effectiveness studies, which are experimental testing of promising behavioral interventions in community settings with community-based providers or caregivers. However, you need to maintain a high level of control to establish the internal validity. Stage 4, which is dissemination and implementation, you sort of drop that worry about maintaining the high level of control. And you now use your empirically supported interventions in community settings. So I'll try to show you how those 4 stages have been implemented in our behavioral intervention work for weight control. So let me just begin with stage 1, the development and testing of behavioral interventions. This area is still ongoing, but it really required many years of research to develop and test an initial behavioral intervention. In fact, the years of 1970s, the 80s, and even some of the 90s were based primarily on these kind of goals. What typically happens in stage 1 is you have very small N's. They're typically from one site. And you're really, first of all, trying to define the important components of an intensive lifestyle intervention. So, for example, there were a lot of studies done comparing diet only versus diet plus exercise and other types of components such as that. There also was research showing that the intensive lifestyle intervention could be standardized and produce weight loss in diverse populations. So that included, in particular, minority populations, and showing that weight loss could produce clinically significant changes in health. Now, owing to the fact that stage 1 is really development and testing of these behavioral interventions, most of the studies were short-term, 6 months, maybe a year. And the health improvements that they were focusing on were things such as cardiovascular risk factors. So showing that if individuals lost 5% of their body weight, they might have an improvement in blood pressure, or et cetera. So that was the type of research that went on in stage 1. And it's still going on, I need to tell you, but it was particularly important prior to the development of these 2 big efficacy studies. Now, stage 2 was this major first real efficacy study in the area of weight loss. It's called the Diabetes Prevention Program. And the goal of the Diabetes Prevention Program, or DPP, was to see if we could prevent or delay the development of type 2 diabetes in people who are at high risk of developing diabetes due to the fact that they had impaired glucose tolerance, elevated fasting glucose levels, and they were overweight or obese. Now, DPP involved 3,000 individuals with pre-diabetes, which is sort of like being like before you develop diabetes and there's warning signs that you're about to develop it, usually with fasting glucose levels. And they're recruited at 27 clinics throughout the United States. These individuals were randomly assigned to one of 3 groups: a lifestyle intervention, which I'll describe in a minute, metformin, which is a drug that's usually used to treat diabetes, but in this case, we were using it to see if it could prevent diabetes, or placebo. Now, in developing the DPP study, as we were investigators from 27 clinics all talking about how to design this study, there was a lot of interest in the medication components, so metformin versus placebo. But there was a lot of disinterest, really, in lifestyle intervention. People believed we couldn't do a lifestyle intervention, wouldn't work, etc. And I argued very strongly that let us at least investigate an intensive lifestyle intervention. Let's set it up to work and see, let's really test a good lifestyle intervention. We received the okay to go ahead and do that. And I became in charge of developing the lifestyle intervention for the DPP. So we were in charge of developing it, writing all the treatment materials, training all the interventionists, and maintaining fidelity of the intervention over time. So the program that we designed for the intensive lifestyle intervention group was based on all that stage 1 preliminary research we had done over the years. We had a calorie goal of roughly 1,200 to 1,800 calories per day, with less than 25% of calories coming from fat. We encouraged participants to gradually increase their physical activity till they were doing about 175 minutes per week of activities similar to brisk walking. And that was based on the fact that calorie intake and physical activity had been shown over and over again to be 2 key components of a weight loss program. And the third component that's so important are the behavioral components, which include self-monitoring of intake, physical activity, and body weight. There are also other behavioral strategies, such as planning ahead, or what we call stimulus control, which is arranging your environment to facilitate your new behaviors. Now, I believe that the goals that we were giving everyone in the intensive lifestyle group were reasonable. The goal was to lose about 7% of your body weight. Now, in all the slides I'm going to be presenting to you, people enter the study weighing about 100 kilograms. So a 7% weight loss is equal to about a 7 kilogram weight loss. And that's going to be true in all my studies because they'll go from percents to kilograms and back and forth, but they're almost always the same, very similar. Now, in the DPP, we used a 6-month core curriculum that involved weekly meetings that were individual between a person and their case manager. And then people moved to monthly meetings, but we maintained the meetings over the entire program. So in many ways, this was a very intensive program because it was individual with 6 months of weekly meetings and then monthly meetings throughout the rest of the study. This next slide shows you the mean weight changes that were developed in this study. As I say here, this is presented in kilograms, but I could have done it in percents and had almost the same numbers. Placebo loses very little weight over the 4 years. Metformin loses about 2 kilograms initially, and then maintains about a 2 kilogram weight loss. But the intensive lifestyle intervention, which is one I really want to focus on, reached our goal of the 7% weight loss at 6 months and a year. And as you can see, there's a gradual regaining of weight over time, which unfortunately is very typical of behavioral lifestyle interventions. Much of our research to date is still focusing on how do we prevent that regain or how do we minimize it. But it is typical to see that type of regain in lifestyle interventions. The other key component was the physical activity component, which I mentioned before. And here the goal was to increase to 175 minutes per week of physical activity. And people in the lifestyle intervention came close to that. This graph is done in met hours per week, but if I translated it into minutes per week, it'd be about 150 minutes in the lifestyle intervention, but very little change in metformin or placebo. Now, the key question in this study was, could those changes in physical activity, and particularly that weight loss, even though they were modest, could it improve the risk of developing diabetes? Could it decrease that risk? This next slide shows you powerfully that it did. So let me show you what happens here. Every 6 months in this study, everybody had an oral glucose tolerance test, which is where you drink a big load of glucose and somebody measures your blood sugars at baseline and then 30 minutes, an hour, et cetera. And you're looking to see if some of those values are too high or elevated. And that defines the development of diabetes. So that's a very intensive test to do, but that is the best way to diagnose type 2 diabetes. Now, in the placebo group over the 4 years of this trial, about 40% of people in that arm developed diabetes. That was reduced to about 30% in metformin and to 20% in lifestyle intervention shown in the green. So intensive lifestyle intervention reduced the risk of developing diabetes by 58% compared to placebo, whereas metformin decreased it by 31%. So lifestyle intervention was nearly twice as effective as medication. So I believe that this was the real study that put lifestyle intervention on the map. It was where everybody said, we got to really, think about lifestyle intervention going forward because it was working so well here. Now, what happened in DPP was that at 4 years, the results were so dramatic that the study was stopped by the Data Safety Monitoring Board, and everybody was given lifestyle intervention. And subsequently, the patients were followed over time in an observational component of the study. I'm sorry. This shows the weight losses in DPP over 10 years. So you can see the first 4 years are shown here at the beginning. But then over time, you can see that the metformin group, which lost about 2 kilograms, and the lifestyle intervention group became very similar as the lifestyle intervention group regained more and more weight. So a pessimist could say, well, I don't think it's going to have any effect now on diabetes incidence. But let me look at the data with you. Here are the 10-year risks of developing diabetes in the 3 arms. And as you can see, the same progression, same effects are shown here through 10 years. So even though the lifestyle arm regained their weight, they maintained the reduction in diabetes risk over 10 years. So this was an extremely powerful study, I think. And it was really, as I said, what put lifestyle intervention on the map. It also encouraged NIH to do other big trials on weight loss. By the way, in the DPP study, not only did lifestyle work, but it worked in all age groups and in all minority groups, all racial, ethnic, different groups, in males and in females, etc. So it's really a very powerful effect. And this led, I think, to the next study that was done, which was Look Ahead, which started really in the year 2000. Look Ahead was a multi-center randomized clinical trial examining the long-term effects of an intensive lifestyle intervention program on cardiovascular morbidity and mortality in overweight or obese persons with type 2 diabetes. So let me just see if I can set the stage for you a little bit better. So DPP had already shown that we could prevent diabetes by weight loss. And then Look Ahead takes over from there and says, but could we treat diabetes by lifestyle intervention? And the main health problem that occurs with diabetes, type 2 diabetes, is cardiovascular morbidity and mortality. So that was the question that we were asking here. Could changing lifestyle reduce the risk of cardiovascular morbidity and mortality in those who already have type 2 diabetes? To address this question, we randomly assigned participants to an intensive lifestyle intervention I'll describe in a minute, or diabetes support and education, control group. The primary outcome, as I said, was a composite measure of cardiovascular morbidity and mortality. Now, the Look Ahead participants included 5,145 individuals. They were drawn from 16 clinical sites throughout the US, and they all had type 2 diabetes and overweight or obesity. Were aged 45 to 76 with a mean age of almost 60. 37% were from minority ethnic racial groups. And in order to enter Look Ahead, they had to have passed a maximum stress test to be eligible. That becomes one of the important factors as we go on and talk about the results of this study. Now let me describe to you a little bit about the study design. The diabetes support and education, which was really the control group, had 3 to 4 educational sessions per year related to diet, exercise, and social support. The intensive lifestyle intervention during the first year had weekly counseling throughout the first entire year. And the goal here was to lose 10% of their body weight. So a little stronger goal than what we had in DPP. This was accomplished by putting everyone on a 1,200 to 1,800 calorie day diet. But in addition, everybody was provided with 2 meal replacement products per day free. So in this case, we were using lean cuisines and slim fast types of meal replacements. Anything that is structured so the person knows exactly how many calories they're eating when they're given these meal replacement products. Now, in Look Ahead, we gave it to them free for 2 meals a day throughout the entire first year of counseling. They also had a gradually increasing goal of getting to 175 minutes of physical activity, very similar to what we had in DPP, and a comprehensive behavioral program. Now, in the intensive lifestyle intervention in Look Ahead, the program was primarily done in groups, but with 3 group meetings per month, weekly, 3 group meetings each week. No, I'm sorry, 1 group meeting each week for 3 weeks, followed by 1 monthly individual counseling session. So it went each month would have group, individual, group, individual. Okay. In years 2 to 4, we maintained monthly contact to help people maintain their weight. In years 2 to 4. In years 5 plus, we moved to quarterly contact to prevent regain. But throughout years 2 on, there were also refresher sessions or small competitions that were held throughout the study that people could participate in to help them maintain their weight losses over time. So I would argue that Look Ahead was even a more intensive program than DPP. Stronger weight loss goal, meal replacement products, and the counseling involved both group and individual. Now, there's certain design decisions we made in developing Look Ahead that you need to know about because I think they're very important. First of all, we decided ahead to enrich the sample of participants with cardiovascular disease history to increase our power. So 14% of our participants had a CVD history. That was because we know that people with CVD history are more likely to have cardiovascular morbidity and mortality over time. We also made the decision to give participants and their physician feedback on their annual blood work and to allow the medication adjustments to be made by the participants' own physicians. And we also allowed ILI to decrease in intensity over time. Now, each of those was done for different reasons, but in part to decrease the costs of delivering this program. Now, this slide shows some of our initial outcome measures. Here's the weight loss. Oh, and throughout these slides, the red lines are going to be the control, the diabetes support and education control. And the blue lines will always be the intervention. So here you can see that the intervention group lost more weight and maintained a better weight loss throughout all 10 years of this trial. Again, if you look just at the first 4 or 5 years or 6 years, you can see a curve that's very similar to the DPP. But here we achieved closer to a 9% weight loss. And even though people were regaining weight, towards the end here, both the intervention and the control group lose weight. That's very unusual in behavioral weight loss programs. We think it may be due to the age of these participants and to an effect of aging on body weight. Now, this shows physical fitness. The way we measured physical fitness was with a maximum stress test at baseline and submax tests at 2, 4, and 8, and 1, 2, and 4 years, And you can see here the intervention group has far greater improvements in fitness at years 1 and 2, and somewhat greater improvements even at year 4. This slide shows waist circumference or abdominal girth, which was also significantly improved in the lifestyle intervention. And this measure is your hemoglobin A1C, which is a different measure of blood sugar control, but is similar for diagnosing diabetes or treating diabetes. So it can be done with just a simple blood test, doesn't take the 2 hours of oral glucose tolerance tests as in DPP. But what you see here is that the hemoglobin A1C and the waist girth and the weight all have very, very similar patterns over time throughout the first 10 years, except for that dip at the end. So how did these changes influence our primary outcome, which I said was a cumulative hazard for, why can't I get it to go now? Okay. Okay, here we go. Wait a minute. Here we go. So these are our main findings in Look Ahead. Now, in Look Ahead, as compared to DPP, our primary outcome was not successful at all. And in fact, while DPP was stopped because it was so successful, Look Ahead was stopped for futility, because after 10 years in the study, it was clear that there was no difference between DSE in the red line and ILI in the blue line in the risk of the primary outcome, which was fatal or non-fatal MIs or strokes or hospitalization for angina. I can't imagine two more similar lines than what you see here. So this shows that over time, both groups developed at greater risk, more likely to have these outcomes, but no differences between the two. There's been a lot of attention paid to why. Why isn't there a difference in Look Ahead? And there have been several hypotheses. One was that the sample was too sick. And that may be because we had decided ahead to accept people who had cardiovascular disease history. And we show that the benefits are in those who are healthiest at baseline. So let me illustrate this to you. This is a non-significant interaction, so it's not significantly different, but it does have some interesting implications. In those individuals who did not have CVD history at baseline, so the healthiest, you have a slight, non-significant, but a hazard ratio of 0.86, slight benefit to having had the intensive lifestyle intervention relative to DSE, i.e. there's less primary outcomes in that group. Okay, you can see the blue line is lower throughout. Now in the group with CVD history, which as I said was only 14% of the population, but here you have many, many more episodes of the primary outcome, which is what we expected, and that's why we enriched with this. But in these sicker individuals, lifestyle intervention shown in the blue actually appears worse. It appears to have actually increased slightly, again, not significantly, the risk of developing heart disease, mortality or morbidity. I want to show you the same kind of thing in another way, which is taking people who are the healthiest at baseline based on something called the deficit accumulation model, which is basically counting up how many diseases a person has. So somebody might have hypertension and sleep apnea. And that would count as 2. Someone else might have those 2, plus also depression or other kinds of health problems. And we add these all up. And in the first tertile, which is the lowest tertile of the healthiest people, they have a slight improvement, actually a significant improvement in their risk of heart disease. The second one was our reference group. And the third tertile, those who are least healthy, have an increased incidence of our primary outcome. So again, very similar to the other slide, suggesting that those who are healthiest when they enter our trial do well, whereas those who are sickest when they enter the trial may actually be hurt by being in a lifestyle intervention program. Now, a second possible explanation for these findings, which we didn't expect, was that improving risk factor management may have improved the health of the control condition particularly. Now, I mentioned to you before that in all cases, participants and their physician were given feedback on their blood sugars and on their hypertension status, et cetera, every year, every 6 months, in fact. So doctors were free to make changes in the medications as they saw fit. So in this slide, you can see here again, the blue lines are the intervention, the red lines are the control group. If I look first at insulin, you can see over time, more and more patients are requiring insulin to control their blood sugar, but it remains lower in ILI than in DSE. Same with statin use. Statins are drugs that you use to lower your LDL cholesterol and prevent heart disease. And throughout the trial, more and more people were put on statins, but the rate of being put on statins was always lower in the intensive lifestyle intervention. And the same with antihypertensive use. Now, what that may have done is led to significantly greater reductions in LDL cholesterol in the DSE group than in ILI. So because patients in DSE were more likely to be put on statins, they also were more likely to have better LDL, or the bad cholesterol, improvements. We know that LDL cholesterol is a very significant predictor of risk of heart disease. So it's possible that because all these participants and their physicians could guess which group they were in based on their weight loss, and the physicians were in charge of the medication, that physicians instituted more medications in DSC. And what you have here is that medication may have been reducing the risk of outcomes in DSC, whereas weight loss was reducing it in ILI. A third possible explanation is that the weight losses we achieved were just not large enough. So let me look at that possibility with you for a minute. This slide looks at the adjusted hazard ratio for the primary outcome according to the amount of weight loss in participants in the ILI group relative to DSC. So if individuals stayed weight stable or gained weight, they're our reference group. They lost a little bit of weight or a moderate amount of weight, they had no significant improvements or worsening. But here, people who lost greater than 10% of their body weight had significant improvements in their risk of heart disease. So again, this suggests that larger weight losses may have been needed, greater than 10%, may be needed to reduce your risk of heart disease in individuals with type 2 diabetes. So I've suggested three possible explanations for these outcomes. But the fourth explanation is that these results were true and that there's no design considerations that explain them, but rather they suggest that weight loss, as we instituted in our program, is not sufficient to cause a benefit or create a benefit among individuals who have type 2 diabetes. However, while that was true for our primary outcome, over time we followed participants in Look Ahead, as we did very similarly to DPP. We followed them as an observational study, and we have shown many significant health benefits of ILI in Look Ahead. ILI reduced the risk of kidney disease, reduced the risk of sleep apnea, led many people to have diabetes remission, to basically become non-diabetic without needing medication, to reduce the risk of erectile dysfunction, reduce the frequency and cost of hospitalizations and the needs for medications, to reduce depression and improve physical mobility. So those are just some of the benefits of ILI. So I think these are two major trials. They were both efficacy trials, but they, I think, set the stage for a whole lot of translation efforts that have been going on since the success of DPP and Look Ahead. I want to accent the ones that have been translating the diabetes prevention program into the community and show you some examples of these trials and some of the pluses and minuses, or advantages and disadvantages in these studies. So these are stage 3 studies. Sometimes they go to be almost stage 4, but these are mainly stage 3. What happened here was that having had the DPP successful results, there was an effort to deliver this in community settings. Given that so many people in the United States are at risk of developing diabetes, diabetes is a very costly disease, you want to do whatever you can to decrease that incidence. We've just shown that lifestyle intervention worked, so let's deliver it now in community settings. But in order to do that cost effectively, they had to reduce the complexity of screening and the enrollment procedures. So the first thing they did was get rid of the oral glucose tolerance tests and either just use self-reported diabetes history, self-reported diabetes risk factors, or they measure hemoglobin A1C. All the assessment visits in the Deploy study are conducted at the YMCA, And in this study, the intervention was actually delivered by the YMCA staff. And the whole intervention is run at the Y because it's got a very heavy physical activity component. In this case, group rather than individual meetings were used. Again, it could reduce cost tremendously. And these were scheduled based on patient availability. In the deploy study, there were 92 participants randomized by center. So 46 of people at one YMCA center were all randomized to the DPP. And the 46 randomized to the control at a different YMCA center were all randomized to control. Okay. Retention in this study was excellent. And the weight losses were also extremely good. A 6% weight loss in YDPP versus 2% in control. So remember, the DPP originally had a 7% weight loss with an individual treatment program. And here in a group program delivered at the Y, we've got a 6% weight loss. So that looked great. However, there was no effect, no beneficial effect on hemoglobin A1C. So there's really no evidence that this lifestyle intervention, which reduced weight, would have affected the incidence of diabetes. Although 1 year is not long enough, or 6 months is not long enough to look at whether you're actually reducing the incidence of diabetes. Now, after that, and based on that success, Ackerman and colleagues did a comparative effectiveness trial. Here, there were 509 participants, all of whom had elevated blood sugar levels. They were recruited throughout different YMCAs in Indianapolis, and they were all randomized to usual care or to the group-based YMCA DPP program. Now, in this case, what happens is that the results are much, much less dramatically good than in the DPP or the DPP, the previous one I just showed you, the deploy study. Because here the mean weight losses were only 2.5 kilograms at 6 months, 2.3 kilograms at 1 year. So a dramatic reduction. It's not clear exactly what led to that dramatic reduction, but probably one of the key factors was that only 62% of participants, of that 509 participants, attended one or more of their lessons. If you don't attend any lessons, you're unlikely to have any weight loss, and that's exactly what happens here. Okay. So you can see that the first thing that happens when you move to a comparative effectiveness trial or a dissemination trial is that the number of people who enter the program may be less good. And we also know that the more sessions a person attends, the better their results. And here, that was true, but only 40% attended 9 or more of the lessons. So that's another problem in these comparative effectiveness trials. So this is another example of translating a DPP program, this case to primary care. There were 241 participants here with prediabetes, and they were all from one clinic. They were randomized to 1 or 3 programs. A coach-led group intervention, so that's pretty similar to what we had in DPP, but group-led. A self-directed DVD intervention. So as part of the efforts to translate DPP and move it into the community, DVDs were developed that people could use at home to watch each of these lessons, and then they could go on whenever they wanted, etc. But each session was like a DVD lesson. And there was a usual care control group. There's a 3-month intervention followed by a 12-month follow-up, and the weight losses at 15 months are shown here. Coach-led program did very well, 6.3 kilograms. Again, very similar to the 7 kilograms in DPP. The DVD did less well, 4.5 kilograms, and the control lost 2.4 kilograms, all significantly different. Now, as we moved more and more toward dissemination of DPP, the effects get weaker. As I showed you in the Ackerman studies, When the second study went on and really became more of a comparative effectiveness study, the weight loss results were less good. So in this meta-analysis, there were 28 distinct studies reviewed, including a few RCTs, but mainly single-site pre-post designs. 12 were in community environments, 11 in healthcare settings, as I just showed you 2 examples, and many of them will use electronic delivery of the intervention. Across these 28 studies, the mean weight change now is only 4%, or about 4 kilograms at 12 months. So again, much less than what we were seeing in DPP. The lay community staff were achieving results very similar to professionals in these studies. And in all these studies, greater attendance is associated with greater weight loss. So one of the problems in these dissemination studies, I would argue, is that the weight losses are less good because the attendance is less good. And that may be because the community settings are less robust at really making sure the person is appropriate, that they understand what's going to be involved in the study, they're really interested in being in the study, and then they join and really participate. Now, I'd like to just briefly mention 2 recent approaches to dissemination. These were both in JAMA in this year. And I was asked to write an editorial about these 2 approaches. So I just want to tell you a little bit about them. One was a study by Hurster et al. That used the MA study design. It was really based on that other study I showed you. It was in primary care, where they had a DVD video. But in this case, they recruited 511 participants from 30 different VA medical centers. They had very few exclusion criteria. These individuals were randomly assigned to the DVD video or usual care. And there was very little contact with coaches. Weight losses at 12 months in this study were based on EHR records. So there's not even a research assistant who's collecting weight losses. It's all being done now from EHR records. It's really much more of a dissemination model. But here, the DVD video group has only a 2.5 kilogram, and usual care has only a 0.4 kilogram. It's like a weight loss at 12 months. It's actually a significant difference, but they're trivial differences. Now, I would argue that in this case, the dissemination approach was not intensive enough to produce weight losses. By the way, it's very interesting. As you move to all these dissemination approaches, you stop seeing any efforts to really prevent diabetes. No measures of blood sugar control, or very limited measures of blood sugar control. And almost never do you see any effects on blood sugar. That's the other thing that happens in these weaker studies. Smaller weight losses and no effects on blood sugar. I wanted to contrast this one with another recent approach to dissemination, which was also in that same issue of JAMA and was the other study I was asked to review in my editorial. This was a community-based intervention. It involved 800 participants with osteoarthritis who were randomly assigned to a weight loss intervention or usual care. And I want to accent to you here that this was an intensive weight loss intervention. It was a dietary intervention that included free meal replacements. There were supervised physical activity sessions 3 times per week. And the group and the individual sessions, both lasted throughout 18 months. The weight losses here were great. They got to 7.7 kilograms versus 1.7 kilograms for the control group. But this study, I would argue, is too intensive to really be disseminated. It's really an approach much more like what we had in Look Ahead, where we involved the meal replacements. It actually went further than Look Ahead in having supervised exercise, and it had group and individual meetings throughout 18 months. So I would argue that between these two approaches, we have one that's too weak to be disseminated effectively, and the other one's too intensive to be disseminated. I just want to conclude by showing you one other study that we've been working on. which is an automated internet behavioral weight loss program, an online program that can be used for weight loss. Now, once again, in developing this online program, we began with a phase 1 period. This was the phase 1 trials for this were actually conducted through a program called Shape Up Rhode Island. Some of you may have heard about and participated in. What we did in Shape Up Rhode Island was we originally looked at what are the weight losses if you just have a campaign to lose weight. And then we added lessons to it. We found that adding lessons helped. Then we added self-monitoring to it. We found that self-monitoring helped. But it was only when we added automated feedback on the self-monitoring that we really got decent weight losses. So we argued that a program that was going to be working as an automated internet behavioral weight loss program for weight loss needed to have those 3 components. It needed to have weekly lessons, a place for people to self-monitor their intake and their exercise and their weight, and then automated feedback, which praised people or guided them if they were not doing well. So we then moved to an efficacy study of this new intervention. We recruited 154 participants who were referred by their physician. They were randomly assigned to an internet behavioral weight loss or to an education-only control. In the internet education behavioral intervention, they received 12 weekly videos over 3 months that taught them about diet, exercise, and behavioral strategies. As I said, there's also a self-monitoring platform for them to use, and they got automated feedback each week. So the feedback would say, John, looks like you had a great week. It looks like you lost 2 pounds this week. That's right on track. However, I noticed your physical activity was not as good as it could be. Perhaps trying X or Y might help you with physical activity. But those were all pre-written, canned messages. In this study, the education-only control was newsletters sent to individuals every week to mimic the frequency of contact. And they were educational materials about diet and exercise. In this study, what we found was that there was a 5.4 kilogram weight loss in the internet behavioral intervention versus 1.3 in the control group. This slide shows you those results. Our website was used 9.4 out of the 12 weeks. And again, we found that more frequent website use was associated with larger weight losses. And there was greater adoption of healthy weight loss behaviors in the behavioral intervention and control. From this, we have recently moved to a real dissemination trial. Now we offered the internet behavioral intervention as part of the primary care program to 1721 patients. Of these, 464, 26% consented and actually started the program. So now what we're doing here in this program is we are no longer having researchers do anything. The program is being implemented pragmatically. There's no therapist contact, no researcher contact. Everything is done by the nurse care managers at this clinic, at these clinics. By the way, it's 38 different clinics. It's all through what's called the Rhode Island PCPC Primary Care, Rhode Island Primary Care Program. So everybody's offered this behavioral intervention as part of primary care. So there's no randomization to a control group. Everybody gets the real program at the beginning. However, of the 1721 patients who were referred to the program, only 26% begin the program. At 12 weeks, though, those people who began the program had a 5.1% weight loss in intent to treat analyses. So that's really an excellent weight loss for a program that involves no therapists, no researcher contact. And the 37% of patients who submitted their weight on all 12 weeks had a weight loss of 7.2%. Okay. So now in this dissemination trial, we're also following patients over time. We will use EMR records to see how they've done over time. And they'll be randomly assigned during that phase to 3 different follow-up programs. But this first phase, this first 3 months, was without any randomization. So in conclusion, behavioral weight loss programs can produce significant weight loss and health benefits. Efforts to study these interventions in effectiveness trials have had only moderate success. Some have been fairly successful, but others have not been successful. And particularly, very few of them have had any effects on blood sugar control. I want to argue that it's very hard to develop an effectiveness intervention that's just right in intensity. It's not too weak to produce a beneficial effect, and not too intense that would make it so costly that it could never be done in community settings. Okay. I think this is our challenge going forward with effectiveness and dissemination trials, is to figure out what are the components that we need and how do we develop an intervention that's just right in intensity to produce good weight losses, hopefully prevent or decrease the risk of developing diabetes or help to treat diabetes and other health problems associated with obesity. So thank you for your attention. I'm happy to answer any questions.
Oh, fantastic. Thank you so much, Rena. That's very interesting and exciting and very extraordinarily clear presentation. And I want to say that the trajectory of this work is the kind of the ideal for clinical and translational research, certainly the ideal for Advance-CTR, which is to use research to improve the health of the residents of our state, of our nation. So this is really spectacular. You know, there's one in every crowd, so I have to ask you, thinking about the DPP observational study where people who did lose weight did regain them, what about using drugs like semaglutide or surgical procedures such as gastric bypass to sustain the weight loss that is originally obtained?
Right. No, I understand. It's a good question. Very good question. I think if we're going to use those approaches, that they should not be used as rescue strategies, as you described there.
Oh.
I think they should be used right from the beginning. Because I think what happens is if a person loses weight and regains it, often after that, if they're in that same program and you say, well, okay, now let's try a medication, it's less successful than if you had started the medication at the beginning. Okay. So I don't think there's been much evidence that rescue strategies have been helpful. We had tried that in Look Ahead, actually. We took a small group of people who had not done well and tried to put them on orlistat, which was a much less effective weight loss medication, but we didn't get any beneficial effects using it as a rescue strategy. So I would encourage people who are going to be using those other approaches to do them right from the beginning.
And if a citizen, if one of our patients wants to lose weight, needs to lose weight, how should physicians refer them in order to get this kind of interventional, intensive interventional program?
Well, that's great question, because I think that's one of our problems nowadays. That's why we were really interested in developing our online program. We have taken our online program, we've given it to RI-CTR-N, this is the primary care program, and told them that they can use it as they want with any patients who want to use it, free. So it's a free program, it works, and people could go on using it. However, it's not being implemented that widely now that we have sort of withdrawn anything that we're doing in the program. Before, we were at least having phone calls with those case managers and saying, let us know if you're having problems getting people into the program, or let us help you sell the program to your patients, et cetera. So I think this is really the other big area. How do we tell people about lifestyle interventions? And how do we, I'm also very struck by these new medications. How do we encourage people to try behavioral weight loss interventions rather than going right to a surgery or a medication? Because I believe behavioral weight loss interventions can be very effective. And they can also not only produce weight loss, but they can also, in addition, lead to healthy eating and increased physical activity, which are unlikely to occur with a semaglutide or other type of medication.
So there's a comment in the chat from Dr. Thomas Anders that there's an online app that WOEBOT, and so for the clinicians in the audience, it might be something else that's worth looking into. Are you familiar with that, Rena?
I'm not, but there might be other people in my group who are, but I'm not familiar with it. But one of the things that's very different in our program than other programs is that ours is really based on DPP. We have materials that are really very similar to those two. Each of our lessons comes from a DPP or look ahead lesson. They build on each other. And there's self-monitoring throughout, and there's this automated feedback throughout. So I think that in other programs, like Weight Watchers has their own online program. Many other groups, Noom does. Many commercial weight loss programs have online programs, but those are not usually as effective as our program is. And I think it's because ours really is evidence-based.
So any other questions in the chat? I don't think I see any right now. At any rate, thank you again. This was very interesting and, to me, inspiring description of many years of really terrific work. And Oaxaca reminds us that we have an evaluation survey that we'd appreciate if people could fill out. And also, I just want to mention that our next speaker in this series will be Professor Eric Morrow, who will be giving this seminar, Distinguished Clinical Translational Research Seminar on February 9th. And he'll be talking about his work on neural development and degeneration. So thank you, everybody. And thanks again, Rena. This was great.
Thank you for inviting me again. Thanks.
Okay.